Osteochondritis dissecans or osteochondral lesions of the knee are a difficult problem, and the traditional treatment for this problem is either ACI or mosaic-plasty. Nowadays, we have developed a technique in which unstable OCD can be managed with fixation using a suture bridge technique, and this technique essentially involves the refixation of the fragment back into its place using multiple knotless suture anchors. So here what happens is a part of the OCD is attached to the PCL on the middle femoral condyle, and we use multiple anchors to fix the lesion. Here we are using a swivel lock anchor loaded with 10 vicryl sutures for the suture bridge kind of a fixation of the OCD. Before that, we do punctures into the fragment on both the sides. Once the swivel lock is inserted with 10 vicryl sutures, then we will be reducing the fragment back into its anatomical position, and then we will try to fix the fragment using multiple push lock anchors on the femoral side. So here we can see that we are fixing the fragment with the use of a pin. So we reduce the fragment into the position and put a K wire for a temporary fixation of the OCD fragment. After that, we use serial push lock anchors. Precisely in this case, we will be using 5 push lock anchors to fix the fragment back into its place. The first push lock is drilled on the medial femoral condyle in the center. We use a purple 7 mm cannula, retrieve 2 of the vicryl sutures, and these 2 vicryl sutures are now loaded onto the push lock anchor, and the push lock anchor is then inserted into the pilot hole made by the drill. The important thing here is to see and to ascertain the flexion in which we have drilled the hole, because if you are changing the flexion angle, you might risk the chances of breakage of the anchor per se. So here what we have done is we have fixed the first push lock anchor, and this will lead to a good stabilization and fixation of the OCD fragment. The important point here is the push lock anchor should be buried inside the cartilage, and it should not be prominent because it may cause a lesion, cartilage lesion later on if it is not buried properly. Now we will be changing the flexion angles and keep drilling anchors on the middle femoral condyle. Since this is a very large lesion, we will be using multiple push locks here. So, and we keep on increasing the flexion and decreasing the flexion to actually fix the fragment. If you want to drill the posterior part, you need to increase the flexion. If you want to drill the anterior part, you want to decrease the flexion. So what here we want to do is we take 2 of these sutures again, and then again we use a push lock in the full flexion to drill the most posterior part of the tendon. Here we need to pull it hard because we want to compress the fragment against the prepared bone bed. So here we need to identify it, we need to push it, and we need to fix it at the level of the most posterior part of the, and then we will be using another one on the anterior aspect. So once we are through with all these fixations, so 1 swivel lock on the PCL side and 5 push lock anchors on the medial femoral condyle side leads to a very nice fixation of the OCD of the MFC, and hopefully this should heal nicely, and this will attain a more biological or a natural healing as compared to a mosaic plasty in which some areas are left uncovered and will be covered with fibrocartilage. Here we will be having a full hyaline cartilage or cartilage. Friends, if you have any questions regarding the technique, you can definitely message us on the comment box. We'll be really happy to help you out. Thanks a lot.